next speaker, I'm very pleased to introduce Dr. Sage Green. Dr. Green has finished her residency and her hematology oncology fellowship at Nemours Children's Hospital in Wilmington, Delaware. She recently joined our group in pediatric neuro-oncology, and she comes to us with an interest in not only neuro-oncology but cancer predisposition syndromes, and she has undertaken the heavy task of growing our cancer predisposition clinic, which NF is one of the diseases that she will be focusing on in her research as she builds that here. We're pleased to add her to her group, and it is my pleasure to introduce her as our next speaker of the morning. She'll be speaking on drug therapies in neurofibromatosis.
Oh, that's me. It's so nice to meet you all, and as Dr. Harrod said, I'm relatively new to the area. I'm from the Northeast, and so I tend to talk a little quickly, so please just flag me if I'm doing that, and I hope to meet many more of you in the years to come. Okay. As Dr. Harrod had mentioned, NF1 is a rare tumor cancer predisposition syndrome. It affects roughly 1 in 3,000 people worldwide, and this condition involves the proliferation of tumors throughout both the central and peripheral nervous systems. And as we know, one of the most prevalent types of tumors in NF1 are plexiform neurofibromas. These tumors arise within the nerves. They affect about half of children and adults with NF1. They grow rapidly through childhood, and this is different from the adult population. And I say this because we need to keep that in mind when we're reading research trials that are being done in mostly adult NF1 populations, because their tumors tend to grow more slowly, and thus they're probably going to experience different reactions and efficacy to the drugs as opposed to children. And they can lead to motor and sensory dysfunction, pain, and disfigurement. When the tumors impinge on vital structures like the airway or the spinal cord, unfortunately, they can also be life-threatening. And all these tumors we refer to as benign. They can also transform to become malignant. NF1, as we know, is autosomal dominant about 50% of the time, but can also arise spontaneously. And this is about an even split of 50-50. We see here the NF1 mutation, which is in the neurofibromin gene, goes down, and the zygote represents the formation of the father's sperm and the mother's egg, and can lead to affected systems in our patient populations, including the skin, which we'll talk about a little bit later. But the changes in melanin can lead to Lisch nodules of the eye, also cafe au lait bacules and other skin manifestations. We also know with the plexiform neurofibromas, it can affect our nerves as well as our neurons and our glial cells in the brain. This leads to neurofibromas as pictured. And also, as we just heard, bones are affected. We can see children with pseudoarthrosis, scoliosis, and a bunch of other manifestations. So the neurofibromin gene is a tumor suppressor gene. And what that means is it keeps things growing slowly over time. That's how it works normally. But when it's mutated in a person who has NF1, the tumor cells grow more quickly. And that is what causes all the symptomatology that is pictured here. And so just to go back a little bit to basics so we can understand more of the medications and where they're affecting our patients and children with NF1, I wanted to go back to cellular biology, which I'm a nerd, so I enjoy. I hope everyone else feels the same. But to recap, our bodies are made up of billions and billions of cells. The cells work together to make our bodies work. Different cells have different jobs, but they all have one thing in common, and each contains genes that are pictured on the bottom there. Genes are the instructions that our cells use to make proteins. Genes tell our cells how to work and what to do. For example, one gene may determine the color of your hair or your blood type. Genes are packaged in the form of chromosomes, which is up on my right side. The information in the gene is coded in a chemical called DNA. There are about 30,000 genes inside every cell. Each person carries 2 copies of each gene. A child gets inherited 1 copy from their mother and the other copy from their father. Every person has 2 copies of the NF1 gene, as I just said, 1 from dad, 1 from mom. The gene codes for a protein called neurofibromin, which, as we discussed a few slides back, is our tumor suppressor gene. And neurofibromin's job is to make sure that certain cells divide and grow in a controlled way. A mutation, which would be a change in this genetic code, that's pictured here by the red mark, so that's an abnormality, that's a mutation in that one chromosome, leads to the neurofibromin protein that does not work properly. This leads to tumor growth, cells just dividing and not knowing how to die as they're supposed to, and this leads to the symptomatology of NF1. NF1 is among a group of disorders that are called RASopathies, and I bolded their path because what we're learning is that our body contains these pathways. Closer. Okay. Sure, sorry. And they're called RASopathies because they're caused by problems in this RAS pathway that's pictured on my left. And RAS pathway is one way that our cells and our body communicate. So just like we all communicate amongst one another, inside of our body there are all these communication pathways going on that we have no idea. And our cells are talking and they're making decisions. And this is one of the pathways that we've discovered in the past decade or so that has been really, really instrumental in the field of oncology and also NF1 and treating RASopathies. This is basically one of the main pathways that determines tumor pathogenesis. But you can see there the neurofibromin. So that, if it's abnormal, it's going to lead to lots and lots and lots of cell proliferation and survival. So cells are supposed to die naturally at some point if they're defective. But if this neurofibromin up there is abnormal, the abnormal cells don't know to die, and they start just to divide and divide and divide and take over and lead to growths in our body. And so there are different parts of this pathway. And over the years, we've said, well, where can we target to try to shut down this uncontrolled tumor growth? And what we're working on now and has been most promising is what I have circled there, MEK. And so the theory is if we can shut down MEK, then we can shut down the abnormality of the neurofibromin, and we can stop cell proliferation that leads to these tumors. And so this is really an exciting age for what is called precision medicine and targeting these types of tumors, where before the mainstay of therapy really has been surgical debulking. And so this is amazing, and we're starting to create lots and lots of drugs, and the basis of these are called MEK inhibitors. Some other medications that we have used in the past can also come from this pathway and that we'll use in the future. So one of those is mTOR, that's over to the side. And so when we think about mTOR, medicines that we can use to target that is going to be everolimus or your sirolimus. But today the talk is going to be on the MEK inhibitors. And so our first drug is selumetinib, and this is the one that most recently has gained FDA approval for the use of NF1 patients 2 years of age and older. And the criteria currently for the use of this drug is that you have to have NF1 and you have to be symptomatic and have an inoperable plexiform neurofibroma. So this indication right now is not talking on low-grade gliomas or aptic pathway gliomas. It is specifically for inoperable and symptomatic plexiform neurofibromas. And so this efficacy of this drug was initially investigated in the SPRINT trial, and that was a National Cancer Institute-sponsored, open-label, multi-center, single-arm trial in pediatric patients who had NF1. You also had to have measurable disease by MRI on this study so that they could track the change over time with the use of the drug. And that, of course, was a plexiform neurofibroma that they were measuring. And this plexiform neurofibroma could not be surgically removed, and that's why you were eligible for the trial. You also had to have significant morbidities or comorbidities to also participate in the trial. And those morbidities include disfigurement, motor dysfunction, pain, airway dysfunction, visual impairment, bladder bowel dysfunction. The patients on this trial received selumetinib twice a day. The dose was 25 milligrams per meter squared, and that's just based off of our body surface area, which is a calculation based off of the patient's height and weight. They had to take that twice a day, and they took it until they had disease progression or unacceptable toxicity. The primary efficacy outcome measures was overall response rate, and that was assessed by the change in the tumor size that they're looking at through MRI of greater than or equal to 25%. So response is going to be taking the medication, having a starting measurement, and then over time, we're going to be doing MRIs, and we're going to do volumetrics. So we're going to look at the size of that plexiform, and we're going to hope that it's changing, it's shrinking by greater than or equal to 25%. And so based off of this, the overall response rate of that trial was 66%. So 66% of the patients enrolled on selumetinib twice a day experienced greater than or equal to 25% shrinkage of their plexiform neurofibroma. And that's a pretty great response. And so this drug now is FDA approved for that indication. The current study that we have open at our hospital is a phase 3 randomized study of selumetinib, and it is versus the standard of care, which is currently chemotherapy with carboplatin and vincristine that patients receive for about a year and a half. And this also is for patients with NF1 and associated low-grade glioma. Most commonly, these are patients who are going to have optic pathway gliomas. And the name of the study is the ACNS 1831. It's through the Children's Oncology Group, which is a very large consortium of oncology studies that are shared by many children's hospitals in the country. And that's really how we share data and how we learn to make children who have cancer better over time. And so just to talk about low-grade gliomas, because they're different from plexiform neurofibromas, they're the most common CNS tumor in all of the pediatric population. And although we don't know why most children get low-grade gliomas, we know that children who have NF1 have a higher increased risk of developing low-grade gliomas. And the location within the CNS, and most often this is going to be optic pathway, so that's going to be hard to resect without great morbidity, including loss of eyesight, makes treatment very difficult. Because really the mainstay of treating a low-grade glioma in a child is going to be to try to cut out as much of it as we can. And we really can't cut these things out. Oftentimes in children outside of NF1, we don't even biopsy these tumors because of the risk of visual deterioration. So in other children who don't have NF1, who don't have a cancer predisposition syndrome, we have some other therapies. We have some chemotherapy that has increased risk of secondary malignancy in a patient without a cancer predisposition syndrome. So of course we're very hesitant to use those cocktails in our patients who have a cancer predisposition syndrome, because the rate of those secondary malignancies are going to be even higher. The other modality that we have is radiation. And again, in a patient who has a cancer predisposition syndrome, we're going to be very hesitant to use radiation in this population. And so, as I said, one of the most common low-grade gliomas in these patients are going to be optic pathway gliomas. And there's one that's pictured right there alongside the optic nerve that you can see on MRI. And about 15 to 20% of our patients will develop a low-grade glioma. And we treat really to preserve vision. So it sounds incredibly scary, right? We're surveilling your child. We find that they have an optic pathway glioma, but if their vision is intact, then we watch and we surveil with imaging. We would not treat. These things are very slow growing, and again, treatment, surgery, they all can increase your morbidity. And so treatment really for patients with NF1 is going to be when we see they have an optic pathway glioma, but also on their ophthalmology exam, we see that their vision is starting to deteriorate, and we want to salvage that vision. And so traditionally, what we had available is chemotherapy. That, as I talked about before, is a course that lasts about 1.5 years. It's a combination of carboplatin and vincristine. But now, as I showed a few slides back, we have a target, which is MEK, and we can attack that in hopes of treating not just the plexiform neurofibromas, but low-grade gliomas and specifically optic pathway gliomas. And so what this trial is, it's a non-inferiority trial. So at the end of the day, we're trying to show that selumetinib is not better than traditional chemotherapy, but that it's not inferior to traditional chemotherapy. And so we don't have data yet for this trial, but hopefully in the next months to year, we will. We do have several patients that I've cared for at my previous institution that have tolerated the drug well. And also what we're looking for is what's called event-free survival. And so the marker at the end of the day is going to be free of negative events such as recurrence, complications, progression, and unfortunately this also includes death. And so patients will be randomized either to receive traditional chemotherapy or selumetinib that is given twice a day over 27 cycles, and those cycles last 28 days each. So although this drug can be well tolerated, side effects are not uncommon and actually is a reason that patients can't tolerate the drug and have to stop therapy prematurely or have to follow a dose reduction. And when we do dose reductions, we have to keep in mind that this is not the recommended dose, and thus it can decrease the efficacy of the medication and not lead to our desired outcome. By far, the most common side effects that I see in my patients are going to be GI related and skin related. I believe in our next presentation, we're gonna talk more about skin, so I'll just touch on that very lightly, but vomiting, diarrhea, nausea, very, very common. To the point that as soon as we see that you don't have an infectious cause for your diarrhea, we could start you on loperamide to try to slow down your stools to make it more comfortable for you. I also often pre-treat my patients with Zofran, especially in the morning, because they might have nausea in hopes that they have better tolerance of the medication. Skin, I would say, tends to be one of the side effects that, depending on the age of the patient, leads some to discontinue therapy. So in children, we tend to see more of this red, blotchy rash that can cover all of the body, whereas in adolescents, it's more of this actiniform, can be even purulent rash. And when you're a teenager and you're going to school and you start having acne all over your body, that's pretty severe. You know, and you already have NF1 and are being treated with a medication for optic pathway glioma, it just makes your life a little bit harder. And so to the point that people can't tolerate and they choose to stop the medication. We also see paronychia, which I think dermatology will also talk on, and that's just an infection of your fingernails and your toenails as well. And then more rarely, but things that we're going to be screening for when your children are taking selumetinib is cardiomyopathy. And so most commonly what we're going to be seeing is a decrease in the ejection fraction, so how well your heart is pumping blood out of the left side throughout the rest of your body. Fortunately, if this occurs in your child, it tends to be reversible. So when we stop the medication, the heart function returns to normal. Things that do not return to normal and that we're always screening for with eye exams is going to be ocular toxicity, and that includes retinal vein occlusion. Also, children, we monitor labs very routinely. They tend to always have an increase in this marker that's called creatinine phosphokinase. That's a marker of muscle breakdown, but fortunately, even when this gets pretty elevated, it doesn't lead to the side effects of rhabdomyolysis, which is something that can negatively affect your kidneys. So it's a marker that we watch. It tends to become elevated, but fortunately doesn't tend to really do damage over time. As I said, the dosing is twice a day. We can reduce dosing based off of toxicity, but then we have to worry about, is the drug still efficacious? I think one of the downsides for this medication, especially in the pediatric population, is that you need to fast before and after you take the medication. And this is a medication that is given twice a day. I find this to be really, really hard for patients. And also you have to be able to swallow capsules. There is a granulation formulation that's in the making, but it's not out yet. But hopefully that will come soon, and then it'll enable younger ages who don't know how to swallow capsules yet to also be able to take selumetinib. So this drug has many benefits. It can be well tolerated, but does have side effects. You need to fast, and you need to be able to swallow a capsule. And so this has led to looking at other MEK inhibitors, including mirdametinib. And this is just one of the studies that I included that has been published thus far for mirdametinib, which is another MEK inhibitor. This is from a phase 2 study. And to keep in mind here is that the starting age for the study was 16 years old or greater. So this does not include children, but it's the same gist as previously with selumetinib. That is for patients who have NF1 and they have related plexiform neurofibromas that are not operable and have led to significant morbidity. And so as I mentioned, this is not a study that has been done yet. Well, this study that's been reported is not done in children. There is an active trial called MEK-NF201 that does include the pediatric population, but that data is still pending. I did have 3 patients on that trial where I previously worked who did have good response for my N of 3 and the drug was well tolerated, but the overall data for that trial is still pending. This trial, keeping in mind 16 plus, what we talked about before, that these tumors tend to grow more rapidly in childhood, the partial response rate here was 42%. So if you remember for selumetinib, it was about 66 to 70%, and here it's 42%. So that's less than selumetinib, but one of the reasons that they postulate that it is less is because it's in the adult population and it's not in childhood. And so if we have a child where their tumor is growing more rapidly, that's going to be more accessible for a drug to take hold of and to shut down than a tumor that is growing more slowly. So that's why they think one of the reasons why they might have a lower partial response in this trial. And so that's why the data that's going to come from the pediatric study, I think, will be very helpful to better understand mirdametinib. This is a drug that is also taken twice a day, but it's not continuous like selumetinib. We take this drug 3 weeks on, and then you have a break for 1 week off. This does come in a liquid formulation. It also comes in a tab. You do not have to fast for this drug. Most common adverse events are pretty much the same as selumetinib. Again, patients are going to have different reactions to different medications. So similar to other things where we kind of have to try and see how we do, your individual child might have more side effects on mirdametinib or selumetinib, but overall the adverse events that were reported for this trial as well as selumetinib were very similar, that being rash as well as GI upset. Mirdametinib tends not to have any cardiac toxicity. but it does have the same risk of retinal vein occlusion. Also interestingly, this study assessed pain, and that was self-reported, and it was found that these patients reported less pain while taking mirdametinib. And one of the things that's interesting there is that that same pathway that we looked at before with RAS and with MAP kinase is also postulated to be involved in neuropathic pain. And so if you shut down that pathway, perhaps then you can shut down the cause of pain of the nerves in this patient population. The selumetinib trial did not look specifically at pain. And then also, these patients, interestingly, reported increased in their cognition. That too was not studied in selumetinib, but mirdametinib is a smaller molecule compared to selumetinib, and so they think that because of that, it can cross over the blood-brain barrier more easily, and then it can have this advantage on cognition. So again, the trial to come with the pediatric population, I think will be really interesting. This mirdametinib had not previously been FDA approved, but it does now have orphan FDA approval status, and that's just a status that we can use for medications that are very rare. And really, at the end of the day, it protects the pharmaceutical company from other competitors when it's under that orphan drug status. So this is something that you can apply for expanded access and get this drug for NF1 patients. And both myself and Dr. Harrod hold expanded access protocols to have this drug at our institution. It would come on an individual patient basis. And so future directions, selumetinib has shown promising efficacy as a non-surgical option for children with NF1. Those FDA approval is specifically right now for the plexiform neurofibromas, and we saw that partial response or overall response rate of 66%, and overall patients are able to tolerate the drug, but it does have known side effects. And then, as I said, also mirdametinib now has orphan drug designation. Again, that's for patients who are greater than or equal to 2 and have NF1 plexiforms that are causing significant morbidity and are not operable. And so big questions for these MEK inhibitors are, when they do have these side effects, can we alternate the dosing? We're not sure. Selumetinib is recommended to be continuous. Mirdametinib, we have 3 weeks on, 1 week off. Perhaps if you're having side effects with selumetinib, you can favor more of the dosing of mirdametinib, but we need more information before we make that decision. Duration of therapy is huge in the NF1 population, as well as the brain tumor patients that I treat. So this is something that's shutting down a pathway. When we take that drug away, what happens? Some patients we see stay still. Other patients, this pathway gets turned back on, and so they start growing their tumors again. Right now, we have a treatment duration of about 2 years. We try to trial patients off at that time and see if they regrow. Why we try to trial off is because we don't know the long-term side effects of these medications. They're very new. So really, it's going to be an individual basis, which brings us to that we need to know more about the predictors of response. So why do certain patients have great response rates and others don't? Why can we stop the drug for some patients, but we can't stop it for others? So hopefully in the next several years, we'll learn more, but I think this is a super exciting time. Previously, we had surgical debulking, traditional chemotherapy. They all have side effects, and now we have precision medicine. So it's a really great, exciting time, and more to come.